Hello, friends. I'm back with another topic that is single fetal demise. This is a very intriguing topic, an intriguing situation for clinicians as to what to do when one of the twins dies in the uterus and the other twin is surviving. So it's a complex question whether to deliver the other twin immediately or whether to wait for some time, whether the died fetus will have any impact on the other fetus, or whether other fetus was already compromised, hence should we hasten the delivery. These are different questions on the obstetrician's mind. On the patient's mind, they will always think that the dead baby is a bad omen. It will do some harm to the other fetus. So they also will pressurize us to deliver the other baby as early as possible. So let's look at what actually should be done in certain situations like this. Single fetal demise is the topic of the day. As I said earlier, this is confronted only in twin pregnancies. And twin pregnancy, as you all know, it could be monochorionic or dichorionic twins. Dichorionic twins are, for all practical purposes, they are like two different babies having their own separate placentae, and they may be independently supplied by the mother. So it appears as though if the single fetus dies in a dichorionic, other should not be having any effect. More or less, it corroborates, but the problem really is in monochorionic twins. So in general, twins have all complications in obstetrics. I used to jokingly tell undergraduates that if you want to list the complications, you should know what is the index in any textbook. So name a complication, it is there in twin pregnancies. Except, of course, the post-term pregnancies will never happen. Usually they will have preterm deliveries. And of course, macrosomia is again almost ruled out in twin pregnancies. But as I said, monochorionic twins have unique complications. In addition to the general complications, they have unique complications. Number one is twin-to-twin transfusion syndrome, TTTS. I have dealt in detail about this in another lecture. Please refer to that in the lecture series. Twin anemia polycythemia syndrome, what is called TAPS. This is also dealt there. Twin reversed arterial perfusion sequence, what is called TRAP. And the fourth one is selective FGR. And finally, it is single fetal demise. Today's topic is single fetal demise. So I'll be talking exclusively on this, but I cannot straight away jump into the management of this. I have to go through the earlier four, but in a brief way because I've dealt it in detail in another lecture. So today's topic is single fetal demise. Can also occur in dichorionic twins, as I told you earlier, but risk of fetal death in monochorionic twins exceeds that in dichorionic twins and even singletons. So this is what I was trying to tell, that the other twin is relatively okay or safer in dichorionic twins, but there can be death, but it is more common in, problems are more common in monochorionic twins. Single fetal demise in monochorionic twins has threefold higher than the dichorionic twins. And SFD was more in monochorionic, that is 11% of 1,329 monochorionic versus 3% of 4,896 dichorionic twins before 36 weeks. These are the statistics. What is a concern? SFD can cause morbidity as well as mortality in the co-twin. That is the worry of the patient, patient party, and doctor as well, due to their shared placenta circulation of a monochorionic twin. Yes, this is very easily understandable because the same placenta supplies to both the twins. So if one twin dies, maybe the placenta is at fault. So we get worried that the other twin also may be affected soon. Or intrauterine environment that caused the death of a dichorionic twin. Yes, there are other situations maybe inside the uterus that may be there for the other twin, surviving twin as well. Can we predict TTTS? TTTS means, the consequences later on. that is single fetal demise. Yes, we can predict that if the first trimester nuclear translucency is more than 95th percentile in one or both the fetuses. Of course, we have to do NT for both the fetuses, right? And if it is more than 95th percentile in one or both, you can suspect that this patient will have TTTS and other complications, finally ending in single fetal demise. Crown rump length discordancy of more than 10% in the first trimester. This again shows that one twin is already suffering right from the early gestation. This is a very important staging, Quintero staging of TTTS. Details you can see in another lecture, but today I'll just mention about them. Stage 1 is oligopolysequence, where the bladder is still visible, Dopplers are still normal. Stage 2 is oligopolysequence is always there, bladder is not visible now, and Dopplers are still normal. Stage 3, bladder is not visible, abnormal Dopplers. Stage 4 is one or both fetuses show signs of hydrops. And stage 5, of course, is one or both fetuses have died. So here today I'm talking about one fetus has died. So how to prevent that? Prediction is over. Prevention. Prevention of SDF, SFD, serial fetal ultrasound examination to stage whether it is Quintero staging, stage 1 or stage 2 or stage 3 or stage 4. Accordingly, we have to take actions, which I'm going to brief shortly. Consultation or co-management of TTTS as per the Quintero stage with maternal fetal medicine. Place like Manipal has got a separate subdivision of fetal medicine, and other places you may have to refer them to a fetal medicine center. So briefly again, management of TTTS. I'm not going to go into the details, but I will just rush through till I come to single fetal demise. There are three primary approaches. Number one is expectant management. Don't do anything if the stage is very mild. And laser ablation of anastomotic vessels if the stage is, just going on to 2, but not really advanced stage. And finally, of course, amnioreduction. This is nothing to help the baby, but it's basically to help the mother. So management of stage 1, briefly. As I said, here the bladder is still visible, even though there is oligopolysequence. Doppler is again normal, so it's a mild stage. The choice of therapy is based primarily on severity of maternal discomfort. If mother is having discomfort because of polyhydramnios, then you will try to reduce the amniotic fluid and give her comfort from the uterine distension. Nothing much for the baby's sake. Cervical length has to be determined. Again, if it is shortened, you may want to offer a cervical encerclage. Again, it is maternal basically, not much to the fetus. Stage 1, no symptoms. Cervix is more than 2.5 centimeters. Avoid intervention. And this to avoid the inadvertent septostomy or bloody amniotic fluid, which would make subsequent laser treatment difficult. So don't do anything heroic at this stage. Monitor the progress. That should be good enough. Now, I'll combine stage 2 to 4 because that's not the intention of the topic. But unless we go through this, we don't understand the management of single fetal demise, which is stage 5. Stage 2 to 4, we usually have the problem of non-visible bladder, abnormal Doppler, and head drops in one or both the babies. So intervention is definitely indicated in these stages. Poor prognosis with expectant management alone. Perinatal survival rates are in untreated patients, it is 30%, and with therapeutic intervention, survival rate goes up to 60%, almost double. So intervention is definitely required. What's the choice of therapy? At 16 to 26 weeks, which is early days, laser ablation is possible and should be done of placental anastomosis is a definitive treatment. We have to offer this. We may have to refer to a higher center, but it is the best treatment. But after 26 weeks, nothing much can be done. Even if you did labor ablation as late as that, you may not be able to help much, but you can definitely help the mother by doing amnioreduction, and follow-up and care is almost same as in stage 1, that is by serial ultrasound, Dopplers for the assessment of the baby. So now I come to management of stage 5. For the details of stage 2 to 4, even stage 1, please refer to my chapter or talk on monochorionic twins. Here I come to management of stage 5, that is single fetal demise, or sometimes there can be both fetus would have died. What is the effect of single fetal death in monochorionic twin? I have already told you a little bit, but let's go into detail now. They can cause following sequence in co-twin. Number 1, acute hypotension. There's sudden hypotension in the second twin. Anemia, because this actually twin would have taken so much of uh, blood from the other twin also, even though this twin has suffered initially, but at the time of death, it would always suck out so much of blood. Ischemia in the co-twin. Of course, anemia, hypotension will lead to ischemia in the co-twin. And due to exsanguination into the low pressure vascular system of the deceased twin. That's what I meant initially. What happens, there is a unequal distribution of the blood supply. That's why this particular baby who died would have had FGR and lack of blood supply and everything, but it will take revenge at the time of death. So there will be some sort of a low pressure vascular system of the deceased twin. So that will something like have a sucking effect from the surviving twin. So it's something like this twin taking revenge for being deprived all these days. The surviving twin will be plethoric usually, whereas the other twin will be always diminished blood supply, diminished oxygen. That's why severely anemic and dies. But at the time of death, there will be some sort of sucking effect, and there can be morbidity in the co-twin or the surviving twin, neurologic impairment 10 to 30%, or death in 10%. So this is the worry, but what I want to reiterate is that it happens at the time of birth, but at the time of death of the dying twin. But once the baby dies, everything is shut off there, and then other twin will not be affected much. So whatever has to happen, it happens at the time of death of this baby. But something different happens in dichorionic twins. What I explained was in the monochorionic twins, the effect of SFT in dichorionic twins. The sequence of hypertension, anemia, ischemia is not a concern. Is not a concern, since there are no placental vascular anastomosis. If you want, you can underline this. I have put not in red and bold. However, there is always an however. Whatever statement we make, there is always an however. Here also there comes an however. Death of one twin may reflect an adverse intrauterine environment that could place co-twin also at risk of morbidity and mortality. So maybe the mother is having some hypertension, preeclampsia. So even though the placenta is totally different, there is no vascular anastomosis. If one placenta was affected due to this kind of pathophysiology in the mother, given time, the other baby also would face the same thing. Other placenta would also face the same thing. Or the other placenta already may be having deficiency. It's just a matter of time. It's just a random occurring. Early versus late single fetal demise. Again, this is a big worry. If the single fetal demise happens very late in pregnancy, then we can think of delivering her other surviving twin immediately. But if it happens early, that's the time we are in a dilemma. While the risk of surviving co-twin is clear in late SFT, it's unclear with early SFT, that is especially the first trimester. Congenital anomalies and cerebral palsy may be attributable to early fetal loss. So the fetal loss of the co-twin may not be due to the vascular differences or due to the placental insufficiency. It may be something wrong with that particular baby itself, anomalies or that. But again, the effect of that could be on the other fetus, which if it goes for preterm delivery, then there could be cerebral palsy. Congenital anomaly in the survivor following SFT before 16 weeks was more than twice. That's what I was trying to tell you. If there was a problem with one of the twins which caused the death, the same problem could be there in the other twin as well. In fact, it is more than twice. What's the consequence of SFT? A 120-gram reduction in mean birth weight can happen for the existing or surviving twin. An increased risk of SGA, that is small for gestational age. An increased risk of preterm birth. That's what I was just mentioning in the previous slide, that there could be a preterm birth for the surviving twin. And that could be the cause of cerebral palsy in that particular twin. So having understood what can happen, now let's see how to manage that. It's a tricky situation, absolutely no doubt in that. But still, we have to be very careful. We should not succumb to the pressure from the patient party. We should have our own assessment and our own decisions, but we can't be autocratic. We can't be saying that keep quiet, I know how to manage. We have to explain to the patient the pros and cons. And before explaining, we must know what are the pros and cons, and we must know what we are going to offer and how we are going to offer. Because sometimes what happens, if we become very bold and take our decisions and something goes wrong, then the patient party will totally blame us. We don't know where to hide our face. So it has to be always a joint decision. That's what is now the whole world is going towards. The decision making should not be taken by the onus should be taken by the doctor only. We should always involve the patient party in the decision making. We must just give the information, right information with all statistics, with all guidelines, and then we should allow them to take their decisions. So the management is same as in MCDA twins without TTS. So whatever it is, the management of single fetal demise with TTTS or without TTTS is same, and it would be same for even the dichorionic twin as well. Neither laser therapy nor amnioreduction can prevent cerebral damage in surviving twin. This is a very important slide statement. If you recall, few minutes ago, I told you, whatever damage occurs to the surviving twin, it happens at the time of death of the dying twin. So thereafter, it's almost like nature has blocked the communication. You don't have to do laser. Why laser is done? Laser is done to block the communication channels, right? So here, once the fetus dies, that communication channel is automatically closed. Now, why no need of amnioreduction? Because once the fetus dies, one of the fetuses die, then what happens? There won't be oligopoly sequence. So that particular sac slowly shrinks and automatic reduction happens. So please remember, there is automatic blocking of the communicating vessels once one of the fetuses die. There is automatic reduction in the amniotic fluid when one of the fetuses died. So that is exactly why I'll repeat one more time slowly. Neither laser therapy nor amnioreduction can prevent cerebral damage in surviving twin. It is not necessary. As the insult occurs at the time of death of the co-twin. I've told this, but I've written this again, and I've made it bold, bigger font, saying that at the time of the death of the co-twin. Nothing happened. I'm underlining also to reiterate the same once again. So what are the management goals? To optimize the outcome of the surviving twin, of course, that's on our mind. At least we want to make sure that the surviving twin doesn't have any problems and has a normal birth or a happy birth or safe birth. To avoid complications of iatrogenic prematurity. This is very important. See, if you get scared or come under pressure and if you immediately deliver, let's say especially before 32 weeks, and then the baby, the surviving baby runs the risk of both lung maturity as well as neuronal maturity. And you may deliver and wash off your hands, but the baby will have lots of problems, especially that of cerebral palsy, and it has to live longer. So you take a judicious decision. A thorough ultrasound survey of the surviving co-twin for growth and Doppler of MCA-PSV. This will give you a very good idea about the blood supply of the baby. MRI 3 to 4 weeks following the fetal demise is indicated to detect intracranial injury. Now, 3 to 4 weeks. I hope that the patients will have patience to wait for 3 to 4 weeks. Usually, they keep pressurizing, especially the patient keeps telling, deliver, 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 because she's scared the other baby will die. So that's why this 3 to 4 weeks, whether we will be able to gain or we'll be able to have is a question. But if you have, then you can do an MRI to assess the intracranial injury. How to monitor in the intervening period? Of course, these are the tense-full days for the patient, for the doctor as well. We have to monitor very, very closely, twice weekly. In a place like Manipal, we may be monitoring every day with the help of PGs and others. But in a private practice, at least twice weekly you have to do. You have to do TCDC to rule out intrauterine infection. This is same as in case of any fetal death, but here it is a single fetal death. And coagulation profile to rule out any coagulopathy. We know all these coagulation factors come into the maternal blood supply, bloodstream. So we have to monitor them. It is rare though. Other parameters, like depending on the comorbidity of the patient, whether the patient has got additional preeclampsia, whether she has got diabetes, whether she has got any other problem, that has to be monitored, goes without saying. There are some miscellaneous issues whether to give steroid prophylaxis or not. It can be given. Beware of pulmonary edema, but you can give this for the surviving twin, especially if the twin is younger and if you want to deliver them lesser than 32 weeks or 34 weeks. What about magnesium sulfate prophylaxis? Yes, again, it can be given if you are especially planning to deliver before 32 weeks. Tocolysis may be given. This is basically to buy a window of 24 hours to allow steroid prophylaxis. And progesterone supplement, yes, you can give. This is also to prevent a preterm delivery now and not for any other reason. Bed rest, of course, it is not beneficial. It can be harmful also. In fact, as I told you many, many times in many lectures, that there is hardly any role of bed rest in pregnancy, except maybe a severe preeclampsia, wherein the patient is given bed rest in the left lateral position. Number two, maybe placenta previa, especially if she has got symptoms, maybe again their left lateral position. Other than that, I don't think bed rest is going to help, especially in the first trimester. Many people advise bed rest if there is a case of abortion in the past. It is not at all required. Patient can be ambulant. Maybe if you have given a cervical stitch for a week after that, there could be a bed rest, especially some people give in a head low position also. But again, it is not required. Time and mode of delivery in general is that delivery timing must be individualized based on the clinical scenario. So one size does not fit all. It also depends upon when the fetal demise occurred, early, late, and things like that. As I told you, if the single fetal demise occurred after, let's say, 35 weeks, there's no point in waiting any further. You can just deliver the surviving twin, because average delivery time of or average pregnancy duration in a twin is as such 34 to 36 weeks. You can just deliver them. There is a faster lung maturity in the twins as well. Whereas if the fetal demise had occurred very early, 24 to 26 weeks, you may want to carry on with the pregnancy for a few more weeks. So it is individualized. There is nothing like a one management for all the cases. You may wait for spontaneous onset of labor. There is no need to induce labor as such. In fact, they may go into spontaneous onset of labor because, when one of the amniotic cavities shrink, there is separation, and this separation from the decidua will always, induce labor by secretion of the prostaglandins. This is a natural process whenever there is a fetal demise, whether it is single fetal demise or a standalone fetal demise. Induction, if there is evidence of deterioration of surviving twin maternal condition, is also deteriorating, then probably you can induce and deliver, because there is no need to do cesarean section as such, because, if there was twin, I can understand, but when one of the fetuses is no more and other fetus is not very big as also, you can always conduct vaginal delivery unless the surviving fetus is less than 34 weeks or if its weight is less than 1,500 grams. So that is a general indication for cesarean section. Otherwise, if the baby is more than 1,500 grams and if it is more than 34 weeks, you can always induce labor and deliver the babies vaginally. Cesarean delivery only for fetal distress or obstetric indication. Suppose, let's say there was placenta previa or the surviving twin is, in the transverse lie. These are the indications. Otherwise, there is no need to do cesarean delivery. Of course, fetal distress is a general indication. It's not a specific indication for single fetal demise. In dichorionic twins, I must give a slide for this. What to do in dichorionic twins. DC twins is not by itself a strong indication for early delivery of the survived twin. This is much better situation than a monochorionic twin because, as I said, this baby has got its own placenta and it's almost now like a single fetus pregnancy. However, if a condition affecting both the twins is present, for example, as I said earlier, mother is having preeclampsia, then the same environment will be there for this baby also. It's a matter of time. This baby also may die because of the preeclampsia rather than because of the twin situation. Chorioamnionitis, again, this will affect the surviving placenta also soon. Then close surveillance and timely delivery of surviving twin is indicated. Timely delivery depends on the condition of the mother. Prompt delivery of in cases of chorioamnionitis versus expectant management of preeclampsia without severe features before 34 weeks. In other words, it's like managing a case of preeclampsia with a single fetus to start with. Monochorionic, the hemodynamic changes and brain injury that occur upon death of one of the twins are immediate. Therefore, prompt delivery after death to prevent damage to survivor appears to be futile. This I've told many times before, that whatever damage occurs at the time of the death of the dying baby. Thereafter, there won't be any damage because all the channels are blocked and this baby is now like an independent baby. It is unwise as well. In the absence of a maternal indication or another fetal indication, for prompt delivery, delivery before 34 weeks of gestation is not recommended. Miscellaneous issues, anti-D prophylaxis, definitely recommended for RS negative mothers. Whenever the baby dies, it is a sensitizing event, so you have to give. Consider heparin therapy if there is an active hypofibrinogenemia related bleeding or if there are thrombotic complications. Yes, that goes without saying. After delivery, keep the cord long for postnatal transfusions of the surviving baby. This is a simple tip. In summary, if I have to say, after single fetal death, prompt delivery of surviving twin is not necessary, not necessary, not necessary. It is unwise also. However, you have to be very careful in monitoring the surviving twin, monitoring the mother against infection, against coagulation problems, and also fetal survival, because we cannot be just taking this particular sentence and say, Dr. Murli said, no need to deliver, just wait, and then you lose the baby. But what I mean by this is, don't come under pressure from the patient party or yourself to deliver immediately and wash off your hands. And no point in giving a very, very extremely premature baby to the neonatologist and expecting him to do all the wonders. So we have to be wise. We have to be prudent. We have to be careful. We have to closely monitor. We have to be sensitive. We have to be very, very alive to the patient, unless the overall situation is unconducive for continuation of pregnancy. It was a short topic, and I thought it was very useful to answer a question in the exam. So I took this topic today. So because the damage occurs at the time of demise and not after that. So this sentence I have told many times, so I made it gray here and I told in the end. Thank you so much. I hope you like the topic, and please share the message to all the new postgraduates who are joining, DNB postgraduates who are, taking exams or joining newly. So this is for all of you. It's going to be free and it will remain free forever. And you please write to me which any topic that you want me to cover, I will cover in the coming days. Thank you so much.